Nirmal Lamechani, and he will be guided and helped by Acharya. Requesting Professor Dr. Nirmal Lamechani to come on the stage. Let's know something about our first speaker. Professor Dr. Nirmal Lamechani is the head of the Department of Neuropsychiatry, Gandaki Medical College, Teaching Hospital and Research Center, Pokhara, Nepal. He is currently serving as the General Secretary, Sark Psychiatric Federation. Each speaker will have 12 minutes and will be notified at 9th and 11th minute. And finally, the screen will be turned off at 12th minute. So it is a request to maintain time strictly. Thank you.
Respected Chair and distinguished delegates, ladies and gentlemen, Assalamu alaikum. What I'm going to present today is, it will be a short workshop, and I request Dr. Achyut Acharya to be ready in the due time, and Anuj to make sure every participant have a pen and a paper in their hands. You know, in COVID era, and this is for the youngster, it's not a good time to fall in love. Going to my presentation, hands-on neurographic art therapy. I have a disclaimer. I am a novice in neurographic art. This is the picture of my guru, mentor, Mr. Hareram Zoziju, who introduced me to neurographic art therapy. Now, what is neurography? Neurographic art is called the art of positive change. It stimulates creativity and imagination. It is a simple way to work with the subconscious mind through drawing, which in a little while you'll know is so easy. It transforms the fear and chaos of our world into something more calming and peaceful. So if you start doing neurographic art, in fact, we have already started it in our patient regularly. Every day, we have 1 hour session of neurographic art therapy guided by our mentors, and the patient really enjoy it, and it has helped them in improving their condition. Okay, this creative method, what it does is, it stimulates new neural pathways by combining art and psychology. It was invented by, or should we say discovered by, a Russian psychologist, creativity entrepreneur and architect, Pavel Piskarev in 2014. So it's a quite new thing in psychiatry. And it has grown rapidly around the world. I don't know if any of the guests here or participants here had heard about neurographic art. Anybody? So this is Professor Pavel Piskarev, who introduced it. So you can see the neurographic art that he has done. And believe me, it's very simple. Today morning, I said that few students came to me and they told me that, sir, we aspire to become a psychiatrist. I told them, psychiatry is a field which has immense potential. I believe what I learned in MD to become a psychiatrist, I don't know about here in Nepal, I think that constituted maybe about 10% of psychiatry. But unfortunately, as an MD, to pass the exam, that 10% is what will get us through. So 90% of psychiatry you have to explore. So in our part of the world, the unfortunate thing is we don't do research. We depend on other researches done abroad in developed countries, and we stipulate it and practice in our setup. So I always say that we talk about Twin Towers and we practice in the ground zero. So as a psychiatrist, being innovative, making meaningful inquiry, relevant discovery, personalized, evidence-based care, and continual growth. If you do that, you have many potential things to do to coin your name in the history of psychiatry. Now, you want to coin your name or fill your pocket with the coins, it's entirely up to you. Now I'll go to the workshop part, and I request the cameraman to show how it is done. So neurographic art is a very simple method. It has certain steps. Okay, so you take your paper. I think you'll need something to support the paper, yes. And draw a line from end to end in the page. It's not projecting there. Can you bring the camera there? Please bring the camera there. Okay, the second step is draw a second line to intersect with the first. Third step would be draw a third line to intersect with other two lines. Okay, make intersections to other two lines. There is no formula, there is no, you can do it in any pattern, okay? It's a form of abstract art, and the beauty of abstract art is it can never go wrong. It can be, the product can be average, good, or excellent. Now you have to identify the intersections, that is where the lines have crossed. Okay, identify the intersections. Make a circular marks to highlight the intersections. And the circle has to be, okay, okay. Now you can start highlighting. Yeah, this is how you highlight it. It's very, it doesn't need any expensive tools. Okay, you can just give a paper. That paper should be white, and your pen should be black to make it more beautiful. Once you complete highlighting, yeah. If you want to make it more innovative, you can move on to make more lines. You can also add shapes, arts, like you can make a star, you can make a moon, you can make hills, you can make sun, and then if you want to go ahead, move forward, then you can use different colors to highlight the boxes that has been created. Achut, remove your hand. Okay, in the boxes that has been created, you can use different colors. Okay, and there is a fundamental rules of choosing the colors that you can find easily in internet. You know, this is the fundamental principles. So yellow, red, and blue are the primary colors, and green, orange, and purple are the complementary colors. So you make choice of your colors like that. This is the initial art that I did. Okay. They say beauty lies in the eyes of the beholder. So you have to find out what it has. So, and what we are planning to do is, we are also planning to do functional MRI scanning in our patient, or maybe whoever does it, and see what changes it brings. I'm sure that it will definitely bring positive change in the mind. Okay, these are some, it is simple sign pens that I used. In this, I had used, I had used colors, watercolors. And believe me, it has done wonder to my creativity. I can sense where it has taken, my creativity has increased. And it has been merely 6 months or so when I started this. And our patients, they are really loving it. This is some innovative pictures that I have done. Okay, this is not exactly neurographic art. In this, I have moved a little forward using alcohol-based sign pens and alcohol spray, 99.9% alcohol. You can try it, but with protective gears. So that, since this is, we cannot demonstrate it here because the fume is very toxic. These were done by my guru, Mr. Hareram Zojiju. This is me. I think I'll end my presentation here. Thank you very much.
Thank you, sir. We have learned very new things. I would like to request Professor Dr. A.H.A. Mustafizur Rahman, sir, ex-professor of psychiatry from the Department of Psychiatry, National Institute of Mental Health, Dhaka, to also chair our session. Our next presenter is Dr. Muhammad Zilur Rahman Khan. He will be presenting on prevalence and associated factors of substance use in Bangladesh. Dr. Muhammad Zilur Rahman Khan is currently working as an associate professor and head of the Department of Psychiatry, Shohid Sohrawardi Medical College, Dhaka, Bangladesh. He is the Secretary of Scientific Affairs in Bangladesh Association of Psychiatrists and the member secretary of the 11th ICP and 13th SWAG International Psychiatry Conference in 2022. Sir, kindly.
PowerPoint share করেন
আচ্ছা পয়েন্ট পয়েন্টার এটা
অন
কাজ করেন
এটাতে হবে
হ্যাঁ পয়েন্টার 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 নাই
হ্যাঁ স্যার এটা স্যার এখানে দিতে হবে স্যার
আমি যখন শুধু পয়েন্টার হিসেবে ইউজ করছি
আচ্ছা স্যার
লাইট না এটা কাজ করে না
করে
Anyway. Thank you, Dr. Jyoti. Also inviting Professor H.M. Mustafizur Rahman sir to chair this session also. Actually, I'm very delighted to present here because those who are present in the dais to chairing this session, they are my direct teachers at National Institute of Mental Health. So, honorable chairs and respected participant from home and abroad. Actually, I'm also delighted to as a member of this, member secretary of the scientific committee of 11th ICP, and because of huge number of participants from home and abroad are presenting this session, this international conference. And actually, I am now presenting an original article that is actually a national survey on the substance abuse, that is prevalence and associated factors of substance abuse in Bangladesh. And this survey was done nearly 2 or 3 years back, and the report has already been published. Wait. Okay. So the title of this national huge sample size committee survey was Prevalence and Associated Factors of Substance Use in Bangladesh. The contributors are investigators are Professor Dr. Mohammad Farooq Alam, Dr. Mekhula Sharkar, Dr. Mohammad Tariqul Alam, Dr. Hilaluddin Ahmed, me, Dr. Mohammad Jilur Rahman Khan, Dr. Reginald Karim, and Dr. Maruf Ahmed Khan. And the conducting authority and funding sources were, this is actually a nationwide multi-centric committee survey conducted by National Institute of Mental Health, Dhaka, with the financial and technical assistance from non-communicable disease NCDC of DGHS. Introduction and background. Actually, we know that substance abuse is a common public and mental health problem in all over the globe, including Bangladesh also. And there are lots of reasons for community prevalence of substance abuse. And we have previously some few small scale survey, but nationwide survey, this is the first time it was done in a huge scale, in the community survey, in a nationwide level, to actually see the prevalence of substance abuse in Bangladeshi population and its associated factors related to it. And economic and social impact of substance use are huge, and substance abuse is a type of common mental morbidity which is defined as chronic organic brain disease. Due to multiple reasons of these disorders are often hidden by individuals and society. And so finally, NIMH, National Institute of Mental Health, with the support of NCDC, undertook a collaborative initiative to conduct the study to determine the prevalence of substance use and its associated factors among people of Bangladesh. The research question was, what is the prevalence of substance use in Bangladesh and what are the associated factors related to it? And regarding the objectives, the general objective was to determine the prevalence of substance use and its associated factor among people in Bangladesh, and the specific objectives were to find out the prevalence of substance use in Bangladesh, to identify the type of substance use in the country, to identify factors associated with substance use in Bangladesh, to identify the common types of mental disorders, and to find out the socio-demographic and psychosocial correlates of substance use. Regarding methodology, this was a cross-sectional study with mixed design having both qualitative and quantitative parts. And qualitative parts includes the focus group discussion, especially to look for the associated factors. The study was conducted during the period of September 2017 to June 2018. The study was carried out in 7 administrative divisions of Bangladesh, that is Borishal, Chittagong, Dhaka, Khulna, Rajshahi, Sylhet, Rangpur. A total of 140 cluster sites were selected randomly in all 7 divisions. And each division, the population was stratified in rural and urban areas. In urban areas, that is called mohallas, and the rural areas called maujas, were selected randomly as a primary sampling unit, was considered as a cluster. The study population, were male and female aged 7 years and above, living cluster, that is the primary sampling unit, during the study period were included those who refused and who were suffering from severe physical ailments, and people living in the residential structures like hostels or dormitories were not included in the survey. And regarding sample size and sampling, the cluster sampling technique was used in the study. As mentioned earlier, 140 clusters were selected randomly throughout the country, and samples were collected from each cluster that were 142. The finally, sample size was determined by appropriate formula for the cross-sectional study, and it was a huge sample size, that is the 19,692. That is actually sufficient for conducting a national survey. And recruiting of the training of the data collector were done. Nearly 20 data collector and 20 research psychiatrists were selected from field work who are regularly monitored in the field level. And regarding data collection techniques and tools, pre-testing was done before questionnaire was finalized, and data were collected by interview using a semi-structured questionnaire for socio-demographic and other clinical variables such as, and other instrument that was used to identify the psychiatric disorders and also screen the level of substance abuse among the community, among the respondents. That is self-reporting questionnaire for children, the alcohol, smoking, and substance involvement screening test, that is ASSIST. Diagnosis of substance use was done by the psychiatrist using the Diagnostic and Statistical Manual of Mental Disorder, DSM 5th version. And data analysis was done by the statistical package for social sciences, and the appropriate statistical tests were done, and ethical issues were maintained strictly throughout the study. This is the characteristic of the sample, that is the population of age nearly below the 18 years age were 15%, and most of them actually are 18 years above, that is 84%. And regarding the sex, it was equally distributed to male and female, that is male were 47% and female were 52%. And the overall prevalence of the substance were found in this huge national sample, community survey was, among the adult population, it was 3.3%, and in the children and adolescent, it was 1.7%. And if we see the distribution among the divisional level, that is most commonly prevalent division was the Dhaka division, that is substance use prevalence was found Chittagong division 3.6%, followed by the Dhaka division, that is 3.2%. And if we see the prevalence of substance use according to the residents, the urban was found slightly higher than the rural ones, that is 3.4% and 2.7%. And if we see the proportion of different types of substance use in the respondent taking the substance was most commonly found was cannabis, that is 42.7%, followed by alcohol 27.5%, amphetamine 15.2%, and others, that is sedative, unspecified, non-alcohol, and inhalant was found around 20.4%. And regarding discussion, the prevalence of substance use was found 3.3% among the adult population and 1.7% among the children and adolescent, which was higher. The previous national health survey that indicates the rising trend of substance abuse in Bangladesh, that is actually 2005 and in 2009, two survey was done. At the survey, the prevalence of substance abuse was found nearly below the 1%, that is 0.6% and 1.3%. Changing societal values added by urbanization, industrialization, and unemployment may be the driving people to the use of substance abuse, which was more common in younger male population. Prevalence of substance abuse among the female was found less around the globe, and this study also showed the lower prevalence among the female ones, that is 0.6%, as opposed to the male that was 4.8%. Individual aged 18 years and above from the most predominant age group of this study, which is also consistent with the other survey findings. Most frequently used substance was include cannabis 42%, and followed by alcohol 27%, and amphetamine 15%, and that was followed by opioid and sleeping pills. Higher rates of substance use was found in extremes of social classes. Individual taking substance mentioned that availability of substance was the commonest, that is the 96.8% was the common cause of substance use, followed by the excess curiosity, that is 95%, pressure of friends, that is peer pressure, unemployment 94.3%, and familiar disharmony and failure in love. And this finding was found statistically significant. A quality part of this research also showed the peer pressure, curiosity, availability of drugs, bad company, lack of supervision and guardians, and bad parenting as the commonest risk factors of substance use in Bangladesh. Now, regarding the strength and limitation of this study, actually the strength of this study was the huge sample size. That is, a COVID survey was done in a large sample size, that is more than 19,000. And another important strength is the probability sampling technique was used, which actually eliminates the biasness and also increases the representatives of whole country. And another important strength was validated assessment instrument were used. That is, the instrument used here are mostly used previously in the national survey more than several times. So this instrument used in this survey was actually validated and very commonly used in other national surveys in Bangladesh. And finally, limitation. As a cross-sectional design, without any control group, the risk factors analysis carries the little value, which is just a statistical association. That is very important, actually. We couldn't see the actually associated factor or risk factor. We could not calculate from a cross-sectional design. We could say that is just mere just a statistical association. So this is an important limitation of this study. And if we want to improve this problem, so further we have to conduct a study that should be either case control design or any analytic design. Another important issue is the estimation of prevalence of mental disorder was not in line with the study of the title, which was a waste of time and resources. Actually, the title was not related to any identification of the prevalence of mental disorder, but it was included actually. So this is, I think, this is a wastage of resources. So finally, a significant proportion of community people were suffering from substance abuse with important risk factors. So further in-depth study is recommended to identify factors which could help in the policy formulation regarding the prevention and control of substance use in Bangladesh. Before I conclude this session, I would like to thank the organizers and the audience and the chairs who spent their valuable time to listen to my presentation. And thank you all. Thank you for patient hearing. I have been concluded nearly 1 or 2 minutes before. Yes, it is, Jyoti? Thank you.
Thank you, sir, for excellent presentation and strict time management. Now I have our next presenter, Dr. Mekhla Sorkar from Bangladesh. Prevalence, she will be presenting on prevalence and correlates of internet addiction among youth in Bangladesh and trial of a cost-effective psychosocial intervention for its mitigations. Dr. Mekhla Sorkar is now working as an associate professor of psychiatry in National Institute of Mental Health, Shere Bangla Nagar, Dhaka, Bangladesh. Currently, she holds the position of academic course director of MD residency program in NIMH, treasurer of Bangladesh Association of Psychiatrists, and executive editor of Bangladesh Journal of Psychiatry, which is the official journal of BAP. So now I'd like to request our associate professor, Dr. Mekhla Sorkar ma'am, to come to the stage for her presentation.
মাইক আছে কোনো হ্যান্ড মাইক আছে হ্যান্ড মাইক হবে না আচ্ছা ঠিক থাক 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 Okay, thank you, Dr. Jyoti, for your kind introduction to me. And welcome to you all to the oral presentation of the 11th International Conference of Psychiatry 2022 in the Chattogram and the venue of the Chattogram. And before my presentation, I would like to thank the organizer for giving the opportunity to present on this topic. So I would like to present before you the original article, that is the research article, which is conducted by the National Institute of Mental Health, Dhaka, the prevalence and correlates of the internet addiction among the youth in Bangladesh and trial of cost-effectiveness, psychosocial intervention for mitigation. This research was actually under the Non-Communicable Disease Control Operational Plan 2020-21 under the 4th Health Population Nutrition Sector Program, Ministry of Health and Family Welfare. And so it is jointly collaborated by the National Institute of Mental Health and DGHS. So I'm Dr. Mekhula Sarkar, already been introduced, so in background, we all know that the internet is characterized by the excessive and the poorly controlled preoccupation, urges or behaviors regarding the internet use that lead to the impairment or distress. So the internet addiction is characterized by the excessive and poorly controlled preoccupation, urges or behavior regarding internet use that lead to the impairment and the distress. So it was variously leveled as the problematic internet use, internet addiction disorder, pathological internet use, compulsive internet use, electronic screen syndrome, smartphone addiction, internet gaming disorder, etc. So the impact of the internet addiction is on multiple levels, and it can impair an individual's physical, psychological, and the social functioning as evidenced by the different study finding. And excessive internet use can also impair the learning, memory, concentration, emotion, regularly sleep disturbance, and social anxiety, depression, substance use, violence, etc., which is also published in the different study research articles. And in Bangladesh, the total number of internet subscribers has reached 112.7 million with an internet penetration rate of 67.3% at the end of January 2021. So in this context, our general objective is to estimate the prevalence and correlates of internet addiction in 10 to 24-year-old Bangladeshi youth and implement the trial of an effective intervention for it. So specific objectives were to estimate the prevalence of the internet addiction in 10 to 24 years Bangladeshi youth, to find out the factors that correlate with internet addiction, to develop and implement the psychosocial intervention. And our fourth objective is to evaluate the trial of brief psychosocial intervention on youth with internet addiction problem. And this evaluation of the trial was measured by the primary outcome measure and the secondary outcome measure. Primary outcome measure is measured by the change in internet addiction score, and the secondary outcome measure was measured by the change in attitude about the internet use and the awareness about the responsible and the rational use. To adopt this objective, to meet the objective, we adopt the methodology, and actually this study was taken place and conducted in two phases, that is the phase 1 and phase 2, in between the July 2020 and 2021 using a global standard methodology. And in phase 1, it was a national household survey where the 2,402 number of 10 to 24 years youth were enrolled and interviewed. Face-to-face interaction from 892 households by the multi-stage random sampling to produce a nationally representative data. So the first phase was the cross-sectional study, which was mainly aimed to determine the prevalence of internet addiction among the specific study group and correlates the factors which is associated with the use of internet. And the second phase was actually adopted a multi-centric quasi-experimental pre-test, pre- and post-test approach where 103 youth with internet addiction problem were given the brief psychosocial intervention by the research psychiatrist. The trial of psychosocial intervention was carried in 10 centers across the country. So in the second phase, it was the 1 month duration, and the brief psychosocial intervention was given by the psychiatrist on the day 0 and 14 of the trial, and internet addiction severity was measured by the internet addiction test at the baseline and the day 30 of the trial. So the target population was in the phase 1, it was the all Bangladeshi youth who are aged between 10 to 24 years who are residing in the household at the time of the data collection. And phase 2 was also the Bangladeshi youth who are the same age population who visited the visited with the complaints of the excessive internet use or the related behavioral disturbance in the psychiatric department of the 10 study centers that I've already mentioned, and who had the score above 36 on Bangla version of internet addiction. And the sampling technique was a multi-stage sampling technique I have already mentioned, and it was collected by the multi-stage geographically stratified probability-based sampling on the basis of the primary sampling unit developed by the Bangladesh Bureau of Statistics for the census 2011. And the sample strategy was multi-center in 8 division and the 64 districts. As we know that the Bangladesh has 6 division and 64 districts, and it was representative from each division. 12 PSU, that is the primary sampling unit, were randomly selected, and thus a total 96 primary sampling unit were selected for the study, that which comprised with the 48 urban and 48 rural PSU. And among the 12 PSU, there was the 6 urban PSU and the 6 rural PSU. So the phase 2 was not the random sampling technique, it was the convenience sampling technique, and the data collection tool was actually the sociogrammic and the relevant information questionnaire, which is the semi-structured questionnaire, and internet addiction test, which is in the Bangla version. It was originally developed by the Kimberly Young, and the brief psychosocial intervention manual, which was given in the second phase, is actually designed by the experts and contains the elements of the cognitive therapy, motivational interview technique, behavioral therapy, and the family therapy. Now the result, I am just highlighting the important finding of this result, not given in a table format or the graph format actually. In our sample that I've already mentioned, the male were mainly dominating, and it was 57% were in male population, 49% were in the urban population. The mean age is 16.7. The mean educational level was 8 years. The students comprised with the 83.3% population, 7.5% were married, and the monthly income of the sample, the mean monthly income was 16.2K Bangladeshi taka. So the overall finding that is in our survey found that the prevalence of internet addiction was 21.4%, and in the distribution of the internet addiction, that's who are addicted, it is found that 28.4% were male and 22.8% were in the urban population, and 10.8% were the age between the 10 to 14 years old. And the distribution of the internet addiction also revealed that the early adolescent age, that is the 10 to 12 years, population actually comprised with 10.8% of the total number of the sample, and up to the JSC, that is the junior school level, it is about, that is the 0 to 8 years, educational level is comprised with the 17%, and students were 21.2%. And when we explored the internet use pattern of the respondent, we have got some finding, that is the smartphone was found to be the most common device to access the internet. 2 or more devices were used by the 39.5% of the respondent. More than half of the users, that is the 54%, had personal electronic devices, and more males were using internet in the morning than the female. However, females surpassed them at noon, evening, and nighttime internet use, though 60.7% females reported that they had no definite time of internet use in comparison to 30.9% male. On average, internet users spent 3.2 hours per day on internet. And the reason for internet use in this study showed that our sample mostly they are who are addicted to the internet are using the watching videos, which is followed by the FM radio, gaming, social media, which is also comprised of the 55.9%, and the news browsing, shopping, and others are also found in the study. And internet use pattern also revealed that in our sample, the male mostly use internet for social media, gaming, news, and browsing, where the female use the internet for the purpose of listening to the FM radio. And men or female were found equal in regards to the watching video and the shopping, and the urban population used more internet for the social media and the gaming, where the rural people used more internet for the FM radio. So the factors associated with the internet use addiction found that youth were 2.89 times more to complain about the internet addiction than the early adolescent. Similar trends were found among the male and respondent from the nuclear family and the unmarried people, individual. No statistical significant difference in the rate of internet addiction was found between the male and urban resident and students and non-students. And those who use internet addiction problem showed statistically significant higher rates of using services like the social media, gaming, watching video, news, browsing, shopping, using electronic devices and internet, and no such difference was observed in case of listening to the FM radio or other reason for the use between those with the addiction problem without it. And respondents with the low mood were 2.7 times more likely to have the internet addiction problem than those who didn't have found the low mood. And similar pattern of increase in addiction were also found with the presence of the social anxiety, sleep problem, smoking, and substance abuse habit. The impact of the brief psychosocial intervention also found then that before the use of internet, they have the 54.70% have the problem with the internet, which is lowered down to the 44.4%. And so I have the shortage of the time, so just our recommendation is the school mental health service should be there with the special emphasis to identify and give the psychiatric treatment to the vulnerable group with the low mood, social anxiety, sleep problem, and substance abuse as the prevention program of the internet addiction. So these are the reference and the data, some pictures of our data collection. So on behalf of National Institute of Mental Health, I am thanking you, all of you, and this research is actually done by the researcher of the NIMS. Thank you very much.
Thank you, ma'am, for excellent presentation on the burning issue. Now we have our another presenter, Dr. Prem Kumar Shanmugham from Malaysia. He will be presenting on post-pandemic and achieving sustainable recovery. Professor Dr. Prem Kumar Shanmugham is an accredited clinical psychotherapist and counselor and clinical supervisor. He is one of the founding member and regional director of the Asia Pacific Certificate Board and founder of Solace Asia, Solace Wellness, and Solace Academy. Now, I would like to request Professor Dr. Prem Kumar Shanmugham for presenting his presentation.
Oh, okay. And I'll be changing this slide with this.
Thank you. Thank you very much, Madam Chair, the organizing committee, and chairs. My name is Prem Kumar, and I am from Solace Asia and Kuala Lumpur, and I work in addictions. I'll try and keep up to the time. My talk today is on post-pandemic and achieving sustainable recovery, mainly focusing on mental health as well as addictions. I think what generally happened over the last 2 years, and we have all seen this, yeah? Mental health as well as addictions has taken a very big place, big topic. This whole conference is about mental health actually. And globally, we are all beginning to recognize that there is a problem and we're beginning to talk about it. Thank you to the pandemic as well in a way. So this probably was something that we would have thought of when we imagined addictions or people with mental health related issues. But the reality of the situation is, this is what has happened today. We are all addicted in some way or another. The research paper earlier presented on internet addiction really was very interesting to me, because if you look at the stats, 20% and above of people who use internet are youth, students. Yeah? In Solace, where we treat people, over the last 2 years, we have seen a rise in people with internet-related addictions, and a majority of them are school-going children. Now, these are some statistics from Malaysia, and if you look at them, we had about 4 suicides per day in 2021. Now for us, and I think everywhere in every country, this is quite scary. And mind you, these are reported statistics, okay? 72% of Malaysians are worried about their mental health. That's almost 3/4 of us have a concern over mental health. And this only happened during the COVID, yeah, during the lockdown period. 80% of us, when I say us, I'm talking about Malaysians, have developed some form of mental illness. Now, this caught my attention more, sorry. The teenagers, 13 to 17-year-olds, 10% of them had suicidal ideations, 1 in 5 have depression, 2 in 5 have anxiety, and 1 in 10 has stress. These were stats, again, that we collected during the lockdown, okay? We spent about 14.46 billion ringgit. RM is in ringgit Malaysia. I think this would be roughly about 3 billion US dollars, I think, 3.5 maybe, US dollars, in economy loss due to the mental health. This was in 2021. Now, if you look here, we spent about 4.46 billion in 2018. So 4.46 billion, and in 2021, we spent 14 billion. Or we lost, yeah? That's a huge, huge jump. Mental health is one of the leading causes of disability and health loss in Malaysia. And very similar to most other countries, here, even in Bangladesh, yeah, we have an issue of lack of expertise. Till today, we do not have enough psychiatrists or enough psychologists in Malaysia as well, and we are struggling. The ratio is now 1.27 per 100,000 population. This was in 2017, if I'm not mistaken. Okay? So there's not much difference actually. These are some statistics that I plucked out about divorce cases in 2020 to August 2021. I don't have the stats for 2020 or 19 here, but I can tell you this is a huge, huge, huge jump. And we can cite many reasons, and some of most of the reasons are very common that you would find here as well. Family issues, relationship issues, inability to manage stresses during the lockdown. That was one of the biggest problems. We didn't know how to talk to each other, locked in a house together. You know, we tend not to speak much. We are so busy with our work. When suddenly we're all confined in the house, we struggle to talk. Okay? Or we end up fighting with each other. So there was a very high rate of divorce cases. Now, what are some of the challenges faced by addiction professionals, people like myself? There was a reluctancy to seek treatment during the COVID. People were afraid to come out. Just like any other treatment, people are afraid to come out and seek treatment. Level of service dropped for various reasons, staff shortage, treatment providers couldn't continue. Solace is a private treatment facility, and we were struggling during the first couple of months or first half year because we didn't know what was going to happen. We just didn't know, like most private agencies. Lack of personal gear, lack of funding, unable to keep up with digital and telemedicine. We had to hire temporary staff, and of course, lowered admission as a result of that. People were even afraid to come out and seek treatment. That was another big problem as well. During the pandemic, what actually helped, what happened was this key thing that I think, which has now become very helpful, the recognition of harm reduction. Now, harm reduction, in Malaysia, now we are trying to call this sustainable recovery. We're trying to use a more positive terminology to explain it. Harm reduction is negative, two negative words. So we have coined this concept called sustainable recovery. So people are more receptive to understanding it. We cannot, just like if you are familiar with opioid, methadone, Suboxone, which has been quite successful. We're trying hard to see if we can implement this with other substances as well. And this became popular, especially during the lockdown. There was a decrease in supply, and more people started taking home methadone, Suboxone, because of difficulty of getting to the hospitals and the doctors. More people were being quarantined in lockdown centers and hospitals, especially those with substance use disorders. And telemedicine became very popular. Telemedicine is new, generally, in my part of the world, though there are people practicing it. But because of the difficulty of maintaining confidentiality, the anonymity, it was reasonably new, but it kicked off and became really popular, and it's growing now. I think telemedicine is the next, is the future. Everything is internet, everything is, online. Some of the factors that increased substance use disorders, as we know, as we have seen in the other research as well, emotional distress, unemployment, isolation. Factors that help to reduce SUD was a reduction in availability. Now, of course, people with addictive disorders are very smart, or very intelligent and very innovative. So we started getting drugs coming in with food to the houses. These food delivery people, when you're ordering food during the lockdown, drugs were found in the paratha, we call it roti canai. Drugs were found in burgers, in packets of rice, and they became more innovative. Financial restrictions, clearly what happened was people were losing their jobs, and there was a difficulty in buying substances, but people started manufacturing them. Now, the policy makers, post-pandemic, they're beginning to review policies and beginning to recognize that, yes, there is a problem. Now, sustainable recovery is becoming more acceptable within the community, and they're talking about it. But there is a clash for resources allocated especially to treat substance use disorders, because people are beginning, or the policymakers are trying to prioritize where should the money go, how much should be funded for this, how much should be funded for that. And sadly, substance use disorder is always the last on the list, as much as we want them to recognize it. Now in Malaysia, we are, or the parliament, or the policymakers are looking into banning the cigarettes, nicotine. So they're coming up with a law where people who are born from the year 2017, I think, cannot purchase cigarettes anymore. So this has caused a lot of commotion within the country, and especially with harm reduction and those who are pushing for harm reduction. Okay, that's my bell. So the 8 pillars, that's a bit stressful actually. The 8 pillars of substance use, I'll run through my slides. Thank you. So telehealth is one of the key things, as I was saying earlier. Telehealth has become a very popular thing now. We're all talking about it. But some of the risk factors, as I said, the difficulty in regulating, evaluating, and less biological testing. Clearly, we can't do lab testing and things like that. More prescriptions. It's easier to prescribe and write prescriptions through the internet and give it out. And of course, lack of clinical quality. The next thing is home hospitalization, which is helpful because now there are quite a few nursing with remote psychological and psychiatric support services. There are agencies which are doing this. It's very popular in Singapore and I think in UK, but in Singapore now, in Malaysia, it's growing. So they have mobile agencies that send out nurses and doctors to the homes when you need them. Consultation lies on psychiatric addiction services, residential services, service centers like ourselves. There are more agencies that are popping up and trying to do rehabs with a multidisciplinary team. It helps to reduce the stigma. And then, as I was saying earlier, sustainable recovery is becoming popular now. Abstinence may be ideal, but achieving abstinence is not as, it's more difficult than reducing the harm. So there's a lot of conversation around sustainable recovery. Person-centered approach. These people started to recognize that you need to be more person-centered, you need to be more, using techniques which are more people-oriented, talking, motivational interviewing skills, cognitive behavioral therapy, solution-focused therapy, positive psychology. Work to promote quality of life for substance use disorders. People are beginning to recognize that you can employ people in recovery. There are people in recovery who are treated and can work. Integrated treatment approaches. This is important because we are working with more other agencies as well, and we are beginning to support each other and refer patients to each other. Finally, continuous education. I think this is one of the most important factors. Because it's not, see, for someone like me, who's a professional I'm working in this field, the concept of sustainable recovery is also new. I come from a training of abstinence. All my life, that was the key thing. But with continuous education, with exposure to the public, exposure to people, and conferences like this, I myself have begun to appreciate the concept of sustainable recovery. Thank you very much. I shall end my workshop here. Thank you.
Thank you, sir, for your excellent presentation. Now we have another speaker, Dr. Niaz Muhammad Khan from Bangladesh. He will be presenting on effectiveness of integrated psychosocial intervention in reducing violence, aggressive behavior, substance use, and suicidal risk among adolescents. Dr. Niaz Muhammad Khan is a general psychiatrist as well as a child and adolescent psychiatrist in Bangladesh. At present, he is working as an associate professor in the Child and Adolescent and Family Psychiatry Department of the National Institute of Mental Health, Dhaka, Bangladesh. He is currently the Secretary General of the Executive Council of the Bangladesh Associations for Child and Adolescent Mental Health and the Organization Secretary of the Executive Committee of the Bangladesh Association of Psychiatrists. So I'd like to request Dr. Niaz Muhammad Khan, sir, for his presentation.
So thank you all, the honorable chairpersons and the respected delegates who are here. I am presenting an original paper about the effectiveness of the psychosocial intervention in reducing the violence and aggressive behavior and also substance use and suicidal risk among the adolescents. Our principal investigator was Dr. Mohammad Tariqul Alam, and co-investigators were Dr. Abrodaj Bhomik, Dr. Helaluddin Ahmed, me, Dr. Niaz Muhammad Khan, and Muhammad Jahiruddin. Nothing to say about adolescent period. It is very much a turmoil period of human life, and lots of mental disorders start in this period. And violence and aggression is very much prevalence in adolescent population. Substance use disorder is also very much prevalence, and NMS survey has also been mentioned. And suicide is the leading cause of adolescent death worldwide, and a recent survey on epidemiology of suicide and suicidal behavior reported by Bangladesh survey, which is 4.7% among the adolescent population in Bangladesh. Adolescent, not, it is youth population below 24 years, 0 to 24. So, the objective of our study was to find out the effectiveness of integrated psychosocial intervention in reducing the violence and aggressive behavior, substance use, and suicidal risk among the adolescents aged 10 to 19 years in Bangladesh. The specific objectives was, I don't want to read it, you will find it through methodology. It is again divided into two phases, the prevalence phase and the intervention phase. Okay. It was July 2020 to 21 study, and study population all Bangladesh adolescents 10 to 19 years of age. And the target population for the phase 2 part was the Bangladeshi adolescent aged 10 to 19 years, visited the 10 service centers where we have collected data from them, where we have given the intervention of the adolescents. Inclusion and exclusion criteria are all 10, 19 years, and criteria for usual place for residence. And exclusion, we excluded the child basically who have some psychiatric disorders, diagnosed psychiatric disorders due to these types of problems. We have used the socio-demographic questionnaire, the aggression scale. Dr. Pamela has developed it, and it is an 11-item scale, and 0 to 6 Likert scale, self-administered, WHO Global School Health Student, School-Based Student Health Survey Questionnaire, and the integrated psychosocial intervention was our instrument for this study. And primary sampling unit was the 96 PSUs and the 496 GATs collecting from the global tobacco survey and also from the National Mental Health Survey that has been done in the 2018-2019. And 6-member data collector team goes to the each PSU, primary sampling unit, and from primary sampling unit they go to the household survey, and from household it is a multi-stage random sampling method from which we have collected data to find out the prevalence of violence, aggression, suicidal behavior, and substance use risk among the adolescent population in Bangladesh. And the phase 2 of the study was to give the intervention, the integrated psychosocial intervention to the adolescent collected from the 10 service centers. Now the result, mean age was almost 15, mean education was almost 7.2 years, and mean father's education, mean mother's education was also 6.1, 5.9. It was almost similar on the every aspect, and Muslim unmarried occupation, among the occupations, students were 90.1%. And okay. Now the result section. The violence and aggressive behavior, we didn't look for any disorder. We did look for a symptom, violence and aggression among the adolescent, and the overall prevalence was 8.9%, and male is to female was 12.1 is to 6.8%. This causes a lot of distress to the child and also to the parents and also to the school. And the overall prevalence of cigarette smoking among the adolescents was 4.2%. The prevalence of substance uses other than smoking in the last month before the interview among the adolescent found was 1.2%, and among the adolescent prevalence of suicidal behavior was found about 2.2%. That means suicide planning in the last 1 month. And we developed the intervention guide with the experts of the field of psychology and psychiatry, with the help of a specific tool, that is the mental health gap, image gap intervention guide, that is version 2. that is developed by WHO, and we have developed this intervention in Bangla. And for the adolescents' family members and also to the adolescents. Quasi-experimental pre and post-intervention approach was adopted, and adolescents were recruited from study centers across the country, and the research psychiatrists were trained beforehand, and each therapy session lasted for 40 to 50 minutes. After the first session, the printed intervention manual was also given to the participant. It was written in Bengali. So that was the violence prevalence number of child with violence that was given. The intervention was 79. Mean age was 16.2 years and 8.7 years, and male 61.4%. These are the socio-demographic intelligence, and psychotherapeutic intervention was given in the day 1 and also at the day 14 of the trial. And we have again given the scales of like aggression scale and the global school health survey scale to the children and to the adolescents after 30 days of the first intervention. And post-intervention score was measured on a day of 30. Wilcoxon signed rank test was done to the post-intervention ranks, and suggests that the integrated psychosocial intervention was effective. How effective? Regarding the intervention of violence and aggression among the behaviors among the substance, it was shown that we have used the Wilcoxon's signed rank test. It is a non-parametric test, and with violence and aggressive behavior, and also the substance use problem behavior, and also the post-intervention in suicidal attempts behavior. These are also very much significant change in their attitude, in the attitude of the child. And also, we have given the parents we have collected data from the parents about how our intervention is effective. They also said that yes, it is almost a new one, and it is also effective one. It was a qualitative part of the study, and from this integrated psychosocial intervention that has been made with the help of the Mental Health Gap Action Program, MHGAP Intervention Guide version 2. In conclusion and recommendation, you can say that the findings suggest the following the intervention program: reduction of the risk in the violence, aggressive behavior, substance use, and suicidal behavior occurred. That means there is a reduction, and it is significant reduction. And low-level psychosocial intervention is needed in our country because it can be done. It can be done by the local health provider, like health assistant, the community community workers. They are working in the government health services, and this Bangla guideline is very much effective for them. So I am at the conclusion of my presentation of this study, and thank you all. Nini?
Thank you, sir, for your excellent presentation and your strict time management. Now I would like to introduce you with our next presenter, Dr. Ruma Bhattacharya from India. She will be presenting on stigma and mental health in SAARC countries. Dr. Ruma Bhattacharya is a consultant psychiatrist. She is the Director Council member of Indian Psychiatric Society and co-chairperson of Committee Stigma and Mental Health of SARC Psychiatric Federation. It will come. She is former president of MP branch and secretary of MP branch of the Indian Psychiatric Society. She is the founder of World of Earth, a welfare society that works towards awareness of mental health and eradication of stigma. Now I would like to request Dr. Ruma Bhattacharya for her presentation.
Good afternoon, everyone. I know it is very difficult after a sumptuous lunch to be awake, so I'll excuse any of you who falls asleep, and please excuse me if I do so. Stigma and mental health of it. This is the next. Thank you. Thank you, Bangladesh Association of Psychiatry, to allowing me to present on stigma and mental health. Yeah, so we all know about stigma, right? Stop mental illness stigma. For that, we have to understand what is stigma. A culture of shame is all too familiar for many South Asians suffering in silence with mental health problems, and discussing psychological health is seen as a taboo within the community. South Asian countries report the highest prevalence of common mental disorders globally. Mental disorders are highly prevalent across the globe, especially in low and middle income countries. Common mental disorders are associated with significant functional impairment as well as social and economic consequences. Depression and anxiety disorders alone cost around $1 trillion per year to the global economy. So when we talk about the SARC scenario, South Asian countries comprise 1/4 of the world's population and include countries like India, Bangladesh, Pakistan, Nepal, Sri Lanka, Bhutan, Afghanistan, and Maldives. It comprises 1/4 of the world's population of low and middle income countries. Marred by high poverty rates, approximately 150 to 200 million people in this region have a diagnosed psychiatric disorder, and they have limited access to mental health. Despite the significant burden of illness, the mental health infrastructure in this region is relatively weak, with less than 1% of total national budgets allocated to it. This is the picture of one of my patients, with permission I have put. So what is stigma? Stigma is a mark, a stain, or a blemish. People with mental illness face stigma all the time by getting treated differently, made to be feel ashamed or worthless. This lady was kept locked inside her home for years, and later, with the help of the neighbors and my NGO, we could rescue her, and she is now under treatment. Stigma is defined as a sign of disgrace or discredit, which sets a person apart from others. Irving Goffman defined stigma as the process by which the reaction of others spoils the normal identity. Stigma is an attribute, behavior, or repetition which is socially discrediting in a particular way. It causes an individual to be mentally classified by others in an undesirable, rejective, or stereotyped rather than in an accepted normal one. Stigma results from a process whereby certain individuals and groups are unjustifiably rendered shameful, excluded, and discriminated against. Stigma is the process of blaming a person wrongly and devaluing him or her for having an illness or being in an undesirable situation. Whereas discrimination means any distinction, exclusion or preference that has the effect of nullifying or impairing equal enjoyment of right. An overt stigma example is like making negative comments about people with mental illness or discriminating against them. A subtle sign is believing and perpetuating the many destructive myths about mental illness, such as the idea that people with mental illness are violent or dangerous. Stigma is when someone sees you in a negative way due to your mental illness. Discrimination is when they treat you differently due to your mental illness. Stigma can lead to discrimination. Social stigma and discrimination can make mental health problems worse and can stop a person from getting the necessary help. Stigma involves inaccurate stereotypes. People with mental illness may be characterized as more violent than the rest of the society. Many say they're just being selfish. If a person is suffering from anorexia, they will say, oh, it's just a fad diet. Some people say to depressed person, oh, you are so lucky, what do you have to be sad about? For obsessives, they say, why can't you just stop? Some say, you're doing this just for attention. And for anxious people, they say, just calm down, stop being so nervous all the time. A person with mental illness may be labeled as crazy, incompetent, or dangerous. A person with anxiety may be labeled as coward rather than having a disorder. People with depression are advised to just snap out of it. Oh, you should think positive. And in India, they say, zyada mat socha karo. Don't think too much. Increase your willpower. When a mental illness is mocked and seeking help is a sign of weakness, that is stigma. Stigma arises from lack of understanding of mental illness, ignorance, and also because of negative attitudes and beliefs towards it. Stigma experienced by people with mental illness can be more destructive than the illness itself. So what are the causes of stigma? Ignorance, misconceptions about the cause or the onset of the disease as a curse from the gods, punishment for one's own sin, witchcraft, black magic, spirit possession, etc. can be the cause of stigma. Cultural factors, belief systems like myths, misunderstanding prevalent in one type of culture can cause stigma. Stigma in the media is especially harmful because the media plays a very important role in shaping and reinforcing community attitudes. Cinematic depictions of schizophrenia are often stereotypic and characterized by misinformation about symptoms, causes and treatments, by portraying violent behavior, dangerous acts and committing suicidal and homicidal behaviors. Medical model implies diagnosis and diagnosis implies a label that is applied to a patient. That label may well be associated with undesirable attributes. For example, a lot of people say mad people cannot function properly in society or can sometimes be violent, and this again will perpetuate the view that people with mental health problems are different and should be treated with caution. Stigma can affect different dimensions and facets of a person's life. It can be present in their own families, people living around, in their community, or in the society as a whole. Let me cite examples. A few months back, Indigo mishandled passenger. A young boy and his parents were not allowed to board the flight just because he was a little anxious. So the crew members felt that he is a risk to other passengers. A delegation of doctors on the same flight requested the ground staff to let the airport doctor take the call on the fitness of the child, but they would not give in, and the child and the parents were not allowed to board the flight. And this was a huge news in the Indian media. I'll quote an example. A 52-year-old married Christian woman who works in a government school and has been diagnosed as having bipolar disorder. She had confided this to her fellow colleagues. And in an instance, in an argument, she responded in a loud and irritable manner, in spite of people knowing that she was suffering from this disorder and she was going through an episode. Another teacher filed an FIR against her. So this is how people with mental illness, people who are labeled with mental illness, are sometimes treated in the society, in their workplace. There was also last week a 22-year-old girl coming from a rural background was brought to me by parents with the complaints of disturbed sleep, abnormal behavior and agitation after her engagement had broken up. But with the suggestion of many in the family and the village, her parents fixed another marriage within a span of 2 weeks. So we can see how marriage is considered so important in our society, and people think that marriage will, heal mental problems. So values and beliefs play a powerful role in creating and sustaining stigma. Some believe that mental illnesses are because of divine curse or is caused by a sin in previous life. Bad karma has caused their mental illness. Marriage is considered very important institution in South Asian regions. Child marriage is still prevalent, and marriage is considered as an answer to many financial, physical, psychological problems in the society. Not only this, people hide their mental illness before marriage and feel cheated if their partner comes out to be suffering from a mental illness. Mental illnesses are considered incurable and permanent defect in the individual. This makes the individual unfit for marriage. Parents of the individual try to persuade the other party for marriage through dowry, gifts or property to compensate for their inadequate child. So there is a study, stigma associated with mental health problems among young people in India, and the results show 1/3 of youth had poor knowledge about mental illness and had negative attitudes. 1/5 intended to or had discriminated against a person with mental illness. Majority of youth potentially recognized mental health problems only if they were acute. Even some mental health professionals have negative beliefs about the patients with emotional symptoms. In USA, every year I go to this American Psychiatric Association conference, and there is this huge rally of anti-psychiatry, the Scientologists, There's a study, myths, beliefs and perceptions. In this study, it was found that almost 50% urban and 30% rural people recognize mental illness as a disease. More acceptance of mentally ill person in rural society. It is found that medical professionals share high proportion of misconceptions and have discriminatory attitude towards psychiatric patients, even against psychiatrists, to be honest. Many a times media portrays mental illness in poor light. Sushant Singh Rajput had died of suicide, and the whole Indian media was, saying all the rubbish. So dealing with effects of discrimination and prejudice is distressing and can exacerbate mental illness. Prejudiced view of others affect people with mental illness. Stigma reduces self-esteem, they make them feel ashamed, embarrassed. So I am not going into the process of stigma. So how to combat stigma? Education, contact, protests, legislate against discriminatory practices, mobilize participation of community members in anti-stigma efforts. This will help. So, share experience of mental health, education by mass by movies is important. There's so many good movies that have dealt beautifully with mental health problems. These are a few. This is from 15 Park Avenue by Aparna Sen. This is Tare Zameen Par. So we all have to fight stigma and reduce discrimination. Barfi was another good movie. Aale Dagi is a Bangladeshi movie which talks on depression, anxiety, phobias. Antora by Bangladeshi director Farid Ahmad won the best film childhood in the pandemic at the UNICEF Film Festival. Mental health matters, end the stigma. Thank you. Signing off, Dr. Ruma Bhattacharya.
Thank you, ma'am. We have questions from our audience, and these are from Dr. M.D. Humayun Kabir. His first question is for Dr. Mekhla Sarkar, ma'am. The question is, what are pharmacological intervention in the treatment of internet addiction?
Actually, it is only the psychological intervention we have applied for this patient, that is in the second phase. The pharmacological intervention were not done, but actually, if the question is, I think this is not regarding to my presentation, probably it is a general question. And actually the internet, there is the loss of the psychosocial and the biological factors which can make a person vulnerable to the internet, as you all know. So first we should assess the patient, we should assess the diagnosis of the patient, and sometimes some people are suffering from the psychiatric disorder. They are also vulnerable to the internet addiction. So first we have to identify the psychiatric problem. If there is any psychiatric problems, then we give the treatment accordingly. Thank you very much.
Thank you, ma'am. And we have another question, and it's for Dr. Prem Kumar. The question is, what are the pharmacological treatment of substance use disorder? Okay, we'll go through the next questions. This question is for Dr. Niyaz Morshed Khan. This question is, what are the benefits from your presentation? What are the benefits from your presentation?
The benefits are manifold, like the surface problems like violence behavior, aggression behavior, substance use and suicidal behavior are going on in our adolescent populations. And if we can intervene and integrated psychosocial intervention earlier, so the catastrophic event like suicidal behavior or substance use problem and violence aggression, that may lead to conduct disorders or oppositional defense disorder, that may be prevented. So promotion and preventive approach, this is a very important study. Thank you.
Thank you to our speakers. Now we have the crest giving ceremony, and the crest. Okay, sorry, sir. For the time shortage, we cannot take any other questions. So, for the crest handover, I would like to request Professor Dr. Shah Alam sir to give crest Professor Dr. Nirmal Lamachari.
Background though. Aziz, banner.
Next, for Associate Professor Dr. Jilu Rahman Khan sir, I'd like to request Professor Dr. Shah Alam sir to hand over the crest. Now I'd like to request Associate Professor Dr. Mekhla Sarkar ma'am to take her crest from Professor Dr. Shah Alam sir. Now I would like to request Professor Dr. A.H.M. Mustafizur Rahman sir to hand over the crest Professor Dr. Prem Kumar. Now I'd like to request our Associate Professor Dr. Niyaz Muhammad Khan sir to take his crest from Professor Dr. A.H.M. Mustafizur Rahman sir. Now I'd like to request Professor Dr. A.H.M. Mustafizur Rahman sir to hand over crest Dr. Ruma Bhattacharya. Now, I'd like to request Professor Dr. Abdul Wahab sir to hand over crest to Professor Dr. Shahalom sir. Now, I'd like to request Brigadier General Professor Ashfaquzzaman sir to hand over crest to Professor Dr. A.H.M. Mustafizur Rahman sir. Thank you, dear audience. Now I would like to conclude today's session and thanks again for your patience hearing. We'll have 5 minutes breaks, and after 5 minutes, we will start our next session. And this session was sponsored by SEPTA. I would like to thank them, and we hope we will have their support again.
আমি একটা আচ্ছা অ্যাসাইন করা আছে একটা প্লে করতেছি